Okay, well, as our students are joining, so good morning, everyone. Thank you for being here again. This is week two of our program, the last week of our program for Future of Medicine, the virtual portion. So please make sure your full name is on your Zoom profile so we can count your attendance. We ask that you have your cameras on while our speakers are talking. Please be respectful and attentive of our speakers, staff, and fellow students. No rude language, bullying, or inappropriate behavior. Please keep yourself muted when not speaking. You can use the chat function to ask or answer questions, and you can also use the raise hand function to wait to be called on, and we will answer all questions time permitting. So we'll move to our first speaker. So Cyrus Botany. MD, Dr. Botany, is a professor at the Department of Radiology at UC Davis Health. So he's a radiologist. And I'll let him introduce himself, and then we're going to open this up, I guess, for questions, which is great because this is a long-awaited specialty that they like to know about. So thank you. Welcome, Dr. Botany.
Yeah, hi. So rather than, I'll give you a very brief background. I am from the Sacramento area. I went to Jesuit high school. I grew up in Fair Oaks, so I'm from the area. If you opt to go into the medical field, um, particularly if you go the doctor route, but even some of the others, physical therapy, nurse practitioner, physician's assistant, dentistry, a lot of us have to move around. So be prepared to potentially relocate to another location, be it for college, for professional training, for the training thereafter, possibly your job. I was okay with that. I've moved around to some other places like Philadelphia, Phoenix, Seattle, um, which is nice. It's a nice opportunity to see some other places in the country. Ultimately, I became a radiologist. I like radiology. It's very much imaging focused. It's very different, though, from most of the other things we think of. When you say, oh, I'm going to be in the medical field, you usually think, I am going to see patients directly. I'm going to face them directly. That is not the bulk of what we do. We look at patients' images and we provide our expert opinion to the doctor and to the patient. So, for example, maybe you have um, gone to your primary doctor and you fall down and you say, oh, I have knee pain. And they may or may not look at that knee radiograph that they order and come to their own assessment, but they'll probably tell you, well, I'll contact you after the radiologist um, interprets it if there's anything else that we should do. So I look at those images and then I generate a report that goes to them, and it may say something different. And then that person, say their primary care doctor, nurse practitioner, whomever, says, oh, well, the radiologist thinks there's a fracture and thinks you should get referral to orthopedics or something like that. The radiologist sees something and that you should get more imaging. Because of the fact that it's imaging rather than seeing patients directly, I actually see way more patients than most people because I'm just looking at their images. So it is not uncommon for me to look at more than 100 patients' images per day. So I have a very big impact on the total number of patients, more than 100 patients per day. Can you name another specialty where you see 100 people per day for patients? I don't think so. That's what's very unusual about radiology. Um, One of the other things that's kind of a trend radiology is very much into tech. So if you're somebody who likes anatomy or likes physics or likes technology, radiology is a good field for you. Um, and it's fairly flexible. People do come in and work, and we see patients, not that many patients. There are some areas where you will see more patients than what I described. I usually see about 4 per day for various procedures. Some people in some areas may see upwards of 20 or 30, but most of us, it's a small handful. But because it's a lot of imaging, there are times where you can read from home. For example, you can work from home. So I joke that this is like one of the best desk jobs there is because I can work from home at times even and impact patients' care. That's about all I wanted to say about it. Um, but what I guess the only other thing I'll add is that radiology touches pretty much every single patient. Um, Almost every patient who shows up to the emergency department, anybody who goes to their primary doctor, they get imaging. So we influence more patients than pretty much any other specialty. Any questions now?
Hi, doctor. So I was wondering, like, sorry, you see, so you see the patient's images like frequently, but you see like a large, like, I guess, magnitude of them. Like, how long does that take you to go through so many images? Is it because you've been working for so long and you instantly like know, okay, they have this or they need to fix whatever? Or does it take you some time to like determine, I need to think about this, I might need to look into it a bit more? What's that like for you?
Your point is well taken. For the majority of us, and in the majority of patients, we look at an image and in less than a second, we interpret almost every aspect of it in less than a second. However, here's the tricky thing. I have to generate a report, kind of like you read, I'll just throw out some book. We'll say like these are older books, like Lord of the Flies or Catcher in the Rye, like older books, and you say, oh, well, I needed to like I was asked to generate like an interpretation of this or my own interpretation. So I had to type something up. That is the part that often takes us several minutes. So while on a radiograph, our determination could be made in less than a second, it often takes us about 3 or 4 minutes to ultimately go through the entire study to generate that report. A small number are exactly as you said. Oh, I don't know what's going on here. Let me ask one of my work colleagues, or let me look something up. That happens at my stage once you're doing this for a while. It happens usually a few times per day, a few times per day. Those ones really slow you down because you end up reading articles and that could take you like half an hour. Now, the thing all of you are thinking about medicine, whatever aspect you go into, keep in mind that continued education and continued learning is a big part of being a doctor, or as I said, being a nurse practitioner, being a nurse. All of those required continued learning. So I came into it, and I'm okay with that. I like continuing to learn more. So I'm okay with a few times per day, I may spend like half an hour reading some articles about something. I hope that answers it. Most of the time, it's on the order of less than a second for X-ray, but sometimes for complicated studies, more often the complicated studies are with CT and MRI, which have more images. Those may take us more than half an hour.
That's very impressive that you get it so quickly.
Yeah. That will come with time. When you first start out, it's not quite as fast. Okay, the question is, do I use or see AI impacting radiology? That is a very popular question. I like that question. So here's the reality. I mentioned if you like tech, radiology is for you, meaning that radiology is willing to embrace AI. As it is now, we could use AI for a lot of things. So as it is now, I have to look at everything, and there's a shortage of radiologists, meaning there's too much work for me now, anyways. So anything that could make me more efficient, I would appreciate, which could be artificial intelligence. Where is it used right now? There are some small areas that it's used. For example, I read mostly radiographs of the extremities, x-rays of the extremities, like your finger, your hand, and looking for things like a fracture. There is at least one, there are probably multiple companies that have generated a system to detect, is there a fracture? Is there a broken bone? Now, those systems are not perfect. Generally, what they do is they are overly sensitive, meaning that they look at it and tell you, I think there may be a fracture here, there may be a fracture there. You have to look at it and more often discount things. Um, right now, the general consensus, though, is that it does speed up people on the whole. If you look at 100 studies, it will speed you up for the majority and make you slightly faster. But sometimes it will be saying things like, oh, that's broken. And you look at it and say, that's not broken. That's the computer is making an error. So sometimes it will slow you down. There are other aspects of AI that could help. Images, as we are now, we look at the images and we generate a report, which is an interpretation. Hopefully it is objective, although there is some subjectivity to it. The AI has the potential to actually give you true data, meaning like it could tell you what is the bone density of every person, giving a number, saying this person's bone density fits X number, and they have osteoporosis. As it is now, we don't do that. We actually tell patients, oh, you should get this special study called a DEXA. So there's a potential for it to provide data as well. There are other things that are more monotonous that we do as a radiologist, which include like measuring things. Oh, how long is the femur? How long is the tibia? How big is this mass? All of those could be computer done, and I just okay it. So AI is being used. AI could help us. AI right now is adopted by some people, and it's maybe slightly making them faster. Um, I would say you will still have a job, though, 30 years from now when you're looking for this. Okay, you have another question. Go for
Sorry,
it.
I had like two other questions because okay, I was wondering what was your journey like for in terms of schooling? Like what did you have to do? And the second one I was wondering was can you specialize in like a certain radiology? Like could I say like, oh, I want to specialize in doing ultrasounds or I want to specialize in like looking at people's brains or like how you do like looking at bone fractures. So those are my two questions.
Yeah, so somebody put in the chat box a very similar question for your first one, right as you were stating it. And the second one I will address first, though. Yes, people do specialize in certain areas. So, for example, I do a variety of things, but I typically look at fractures and arthritis all day. So I'm mainly looking at x-rays of people's knees, hands, feet. those types of things. And other people may look at just brain MRIs, head CTs. I'm just looking just this area and above. Like, why do they have a headache? They fell down. Do they have intracranial hemorrhage, bleed within their brain? So yes, you can totally specialize. There's a trend towards specialization in general across the country for this and for a lot of other specialties. And the reason being that the quality improves when you deal with one area regularly, you become more of an expert in one area. Okay, the journey and the schooling. So what I'll first say, I was slightly more accelerated than most people. After high school, I went to UC Berkeley. I graduated in less than 4 years, and I graduated with a degree in molecular and cell biology. Um, I would not necessarily recommend what I just said I did. I would say enjoy college and pick a major that you think when you graduate from that with that if this doesn't work out, I have a good backup plan. So if I were to go back, even though I did get into medicine when I was an undergrad, I would have chosen things that I really found interesting then, like nutrition. Actually, nutrition has a lot of overlap as a major with the prerequisites for medical school. But if it didn't work out, I would have been okay with it. Um, so after I graduated from UC Berkeley, I did not do a gap year. It's very common for people now because they feel like, oh, I don't have enough experience, or I don't have enough research, or I didn't have time to study for the MCAT. The MCAT being the entrance exam for medical school. They'll often take 1 to 3 years off between college and medical school. I lucked out. I went from college to medical school. Um, like I said, not totally normal. I took my MCAT between the second and the third year of college. Most people take the MCAT in their third year or later. You have to keep in mind when you take that exam that the results need to come out and your application is usually submitted in the summer. So, meaning that if I were to apply, say, as a beginning of my fourth year of college, I need to have the MCAT score before that summer, which may mean that you took it between second and third year like myself, or you took it earlier in your junior year. Then I went for 4 years of medical school. 4 years of medical school, that was in Philadelphia. Then radiology requires you to do an intern year, which is an introductory year of something. In this case, it was internal medicine. Usually it's in surgery or internal medicine. Radiology residency is 4 years. And then people usually, to that question of do people specialize in areas, then I did actually 2 fellowships. That's kind of atypical. Usually people do 1 fellowship that lasts a year. So what does that mean? That means after you graduated from high school, if you're even on the accelerated pathway, you had 4 years of college, 4 years of medical school, that's 8 years, and then you had another 6 years between intern, residency, and fellowship. So 14 years. This is what I like to say is delayed gratification. If you're okay with that, the 14-year plan. I'm assuming many of you are not or may not be in your last year of high school. So maybe it's more than 14 years. Maybe it's 16 years from now. Okay, other questions?
Who else has questions? I have one. What's the hardest part of your job?
The hardest part is the imaging volume continues to increase. And so there's just this demand more and more that you just need to keep doing more. Oh, what's my favorite part of the job? Well, my favorite part is that well, there's so many, but I would say the fact that it's very flexible, very flexible. The fact that I influence so many patients, the fact that it's very anatomy based. I really like anatomy. So that nicely fits. And I like the fact that it's pushing boundaries on technology. How is the work-life balance? Okay. So what I would say is that it's relative to other doctors, it's fairly good in that there's flexibility. Meaning, like, well, I'm doing this right now. The next doctor, maybe she had to do this on an off day, or she has to like rearrange her operating room schedule or her clinic schedule. I can just, if I need to go do something for an hour, I just step away. It's not a big deal. The work is still there though. So I would say that most radiologists work about more than 50 hours a week, but it's a very flexible, meaning it's not like, oh, I have to be there from 8 a.m. to 6 p.m. or I have to be there like some specialties. I have to be there from 6 a.m. to 6 p.m. on some days. It's not like that. It's like, well, today I have things going on. I'm going to start working at 10 a.m. and work till 6 p.m. And the other day it may be 8 a.m. to 5 p.m. And there may be things that I'm doing throughout the day. A fair number of radiologists are also part-time, which is easier to do in radiology than some other specialties. I hope that answers that one. And then there was a question of I recommend pursuing a major unrelated to. Um, so the answer is I would recommend doing a major that you really find passion in. Um, in that it's then a good backup plan if this medicine thing doesn't work out. Now, could that end up increasing your college time? Possibly. I understand that's a challenging thing, but I like to have backup plans. So I would suggest if you're going to do something as far as a major, do something that you like. Don't go the route of, oh, I have to be a biology major. Or that they have a pre-med pathway. Don't necessarily assume you have to go on that pathway. Any other questions?
Any other questions? I have a question. What's one case that stuck with you?
One case that stuck with, well, unfortunately, here's the thing. We remember our misses. That's now you learn from that as well. But I can think of a few, particularly when I first started in my career. I can think of a few misses that not that they cause any harm to the patient per se, but that I just, oh, I should not have said that. There was a question of what inspired me to become a radiologist. Well, it actually did not come from it did not, when I was in medical school, it did not come from working with radiologists. It actually came from being on other areas like orthopedics and internal medicine, where I realized I really like looking at the imaging of those patients, particularly in orthopedics. And then the other thing that was a very big influencer was while I was on my surgery rotation, there was a resident there from radiology who gave some teaching sessions to all the people there. and for a bunch of medical students mostly, some residents who are on the surgery rotation. And I just thought that person really knew their stuff. I was really impressed by them and just seemed like a good role model. So it was other areas and then one individual with their teaching session. Anything else? Who helped me along the way? Oh, well, I would say one of the things that was really helpful was I knew somebody who allowed me to work in their medical office when I was a college student. That was very helpful in at least seeing some aspect of medicine, which for all of you who are in this program, you're at least getting some introduction into medicine, which is good. Um, that was helpful. In terms of the mentors that I had, more subsequently, it had to do with people who were once I became a resident. Um, if I mentioned physics, can you still pursue radiology if you don't like physics? Certainly you can. I will just say you definitely have to like anatomy though. If you do not like anatomy, then I would say probably radiology is not the field for you. There are plenty of other medical fields. But physics not a make or break thing. Um, what next steps do you take if you do make a mistake? Uh, could you specify wherein, like as say as a attending radiologist, if I misinterpret something? I guess I'll use that. And maybe you mean some other aspect, but what if I made a mistake on an interpretation? Well, here's the tricky thing. Oftentimes you don't know what you missed, meaning you don't know what you don't know. Um, so many times you're just completely unaware. Now, if somebody, often the way you find out about the misses you make is somebody will tell you, oh, you missed this fracture. So you go back on it, and usually the person who tells you is a follow-up study by another radiologist. Sometimes it's by a clinician who is seeing the patient. If it happens to be that clinician, you tell them thanks, and if that initial report doesn't state it, you will addend the report saying there was a fracture, and this person will just say Dr. Smith of primary care is already aware of it, just so it's then in the patient's medical record, so everybody knows there's a fracture. Um, we have some other areas where we internally, like every month, go over things that people in general missed. So that's an opportunity for us to learn from one another. Um, it's 10:30, so I think I should stop there. I really appreciated all of you asking questions. That's what I liked. This is about you, not me just blah blah blahing.
Well, thank you so much. If we have any additional questions, I'll shoot you an email and let you know. But thank you so much for being on today, everyone. Please thank Dr. Botany for being here. We really appreciate you taking the time. Thank you.
See you. Thank you.
All right, we're going to move to our next speaker. So Dr. Clara Paik is a clinical professor and vice chair of the Department of Obstetrics and Gynecology at UC Davis Health, and she currently serves on our board here at SSVMS. She mentions that one of the things she loves about her profession is she's been able to teach and mentor medical students, residents at UC Davis for 25 years. So welcome, Dr. Paik.
Thank you, Sam. Thanks for that kind introduction. Hi, everybody. I'm so happy to be here and talk to you all. Like Dr. Botany just said, I welcome any questions as I am talking. Please feel free to interrupt me. I can't always see the chat, but I'll try to monitor it too to see. But Sam, please feel free to chime in if there's a hand up or a question. I'm happy to answer as I'm talking
Okay.
because I would love to have the interaction as well. Okay, so Sam gave me that very nice introduction. Am a clinical OBGYN at heart, but I also teach students and residents at UC Davis. And so I have been part of the UC Davis Medical School for 25 plus years. Um, so I just wanted to say a few things about obstetrics and gynecology, and women's health in general. Um, so obstetrics and gynecology, the first thing people think about is, oh, delivering babies. But there's so much more to obstetrics and gynecology than delivering babies, although that is a very fun part of what we get to do. We also do many surgeries. A lot of people don't understand that obstetrics and gynecology is kind of a surgical field. What I like about, because there are other physicians like family medicine physicians that can deliver babies too, but we can also go all the way to the end and deliver by C-section if there's a problem with the mom or the baby. Um, so, many fields to obstetrics and gynecology. I am a general obstetrician gynecologist, but there are many fellowships that one can do if you enter the field of obstetrics and gynecology. One is being like a infertility specialist. They are the ones that do um, in vitro fertilization for women and couples having infertility problems. There is family planning, which are specialists in contraception and abortion care. There is maternal fetal medicine, which is they concentrate on women with high risk pregnancies, so women who have medical problems like cardiovascular problems or diabetes, um, other complex medical problems. And then there's pediatric and adolescent gynecology. We call that PAG, PAG. There's minimally invasive gynecologic surgery. We call that MIGS. They do robotic and complex laparoscopic surgery on female reproductive organs. And then one of the other ones that is very popular is gynecologic oncology, which is cancer care of like ovarian cancer, uterine cancer, fallopian tube cancer, any of the reproductive organ cancers. So those are many of the other subspecializations when you become an obstetrician gynecologist, you kind of realize, oh, I want to do this. It's same thing as like you're in high school and you're like, I gravitate toward this, or when you're in medical school and you're like, or when you're in college and you're like, I like biology, I like English. You just kind of naturally go in the direction that you feel like, oh, this is an interest of mine and I'm passionate about it. There are also many job opportunities available in obstetrics and gynecology. Oh my goodness, there is such a shortage of OBGYNs in the United States and in California in particular. The job opportunities are there if you enter the field of obstetrics and gynecology. There's also many different things one can do as an OBGYN. There's academic medicine, which is what I do because I love teaching students and residents, and doing things with residents and students. But you can do private practice where you can have students and residents with you, but most of the time they're facing with patients more like of in a private practice sort of way. And that's something that is a preference. They usually share opportunities with their colleagues, and they have to have kind of a business mentality because you have to keep your practice like floating, and you have to be able to, make money for your family and other things. There's a Kaiser that which is huge in Northern California and other parts of California. And these physicians can also teach students and residents. That's not necessarily exclusive, but they face with patients kind of directly, and they get paid a salary. So they don't have to worry about the business aspects of keeping their private practice group afloat. So training for OBGYN is, the standard traditional way is college. You can major in anything you want. You just have to take the pre-medical requisites or the pre-medical classes. And then you take the MCAT, you apply for medical school. You go to medical school, which tends to be 4 years. And then in medical school, you kind of direct I want to go into radiology, I want to go into orthopedics, I want to go into OBGYN, I want to go into family medicine or pediatrics. And then you decide. And then obstetrics and gynecology, the core residency is 4 years. And then after that, if you want to subspecialize, is an additional 1 to 3 years. Like if you want to be a GYN oncologist, that's an additional 3 years of fellowship. So 7 years total after medical school. So everybody's like, wow, that's a long road. If you are passionate about something, you take it one step at a time, you do it, and then time flies, and then all of a sudden you're going to be there. Okay, so any questions so far, guys? Let's see, just want to make sure that I get to anybody who has any
What
questions.
questions do you guys have?
You don't have to, but I just want to stop and make sure if anything's
Yeah,
confusing. Oh,
Jillian.
yes, Jillian.
Oh, okay. So you mentioned that you do teach students and residents. What exactly is that like? Are you also you said you also do like you're also a clinical OBGYN, so are you treating patients and you're a teacher and professor at the same time?
Yes. Oh, that's a great question, Jillian. So basically, I have a day in a week where I have my own clinic where I see my own panel of patients. So those patients know they're seeing me and I'm going to see them. Sometimes, though, I will have a student with me. And if it's okay for the patient, the student can sometimes go in and talk to the patient first before I come into the room. Or if I'm working with a resident, the resident will see the patient first, kind of tell me about what's going on with the patient, and then I'll go in by myself or with the resident. Sometimes I'll have both of them, student and resident, and then they'll sort of tag team with some of my patients. In an academic setting, there's also OBGYNs. Residents have their own clinics. So sometimes I'm in a supervisory role where they're doing their own clinics and I'm supervising 3 or 4 of them doing their own clinics. And I'm kind of sitting in a room. They tell me about the patient. If I need to see the patient too, I'll go in with them, but I'm going and managing several different rooms while the residents are seeing their own patients. Um, so that's mainly it. And then, of course, we have students and residents whenever I'm on labor and delivery, or if I'm in the operating room, they will be either doing, like if there's a resident, they'll be actually doing the surgery. Um, and the student will usually be in a like observant role there. Did I answer your question?
Yes, thank you.
Oh, thank you. That was great. That was a great question. Okay, guys.
We have some
Um,
questions in the chat, actually.
oh, great. I didn't see those. Let me see. Oh, we do have a lot of questions. Oh, great. Okay, let's see. Well, you're welcome, everybody who said thank you. How do you encounter any difficult diagnoses that you have to communicate to a patient? Oh, wow, that's great. Thank you for that question. So we do have to actually do many difficult diagnoses with patients. Sometimes you have to tell a patient that they may have um, cancer, or they have a young woman who has a cyst on their ovary that may have to be removed. Many patients come with their own struggles, pain, anxieties. And how do I deal with that is, first of all, you just have to really try to be empathetic for the patient that's in front of you. They are coming to you for help. And you, depending, this is where I kind of call it the art of medicine. Some patients, you can tell they want you to just say it straight out. And they're like, I can take it. Just tell me what it is. There are other patients who want you to kind of, slowly take them through. They have a lot of questions. You have to be patient in answering each and every one of those questions. And we encounter that all the time, every day, all day. It's one of the tough things that we deal with, but some of the most I would say satisfying and challenging things we do as physicians is to break bad news in a caring and positive way, so that, because one of the great things about OBGYN is that you can actually solve a lot of problems for patients. You can actually do something about what patients are coming to you with. So I hope that answered your question. Um, and then what's my favorite part of my job? Oh gosh, there are so many, guys. I love what I do. And even though it was a long road, believe me, I'm not going to lie to anybody and say, oh, it was so easy. No, it's a long and arduous road. You have to just be persistent, though. And there's no one that can stop you from doing what you want to do if your heart and soul is in it. And my favorite part, okay, so I was just on call on Saturday and I got to deliver twin babies via a C-section, and it was just so fun. So delivering babies, definitely, I still love that. It's just a beautiful moment. And the other great part about my job as an OBGYN is women come to you with the most sensitive things that they won't tell their mother, that they won't tell their partner, they won't tell their best friends. I am privy to a lot of what bothers them deep inside their core, and I get to help them. And that is a great part of what I get to do. And I do not take it for granted that women and young women, older women, they are sharing their most intimate things that they won't tell anybody else. And they're telling them to me because they trust me. They feel like I can help solve their problems. So that's another favorite part. And I also really just like to also operate. I mean, I still do it. And it's a operating is another kind of dopamine hit, because it's like, okay, a patient comes to you, they have a mass, you remove the mass, you make them feel better. It is a great thing to be able to do for people. And it's something that we are capable of doing. So it's just a wonderful aspect of my job. So thank you for that question. All right, guys, I am going to just continue with my um, train of thought. Okay, so I talked to you guys about training. That's traditional training, but I will tell you, we have so many residents that I work with that come from all sorts of backgrounds. Okay, we have residents who have physician fathers. We have residents who have physician moms, but we also have many, many residents who have, they're the first ones to graduate college. They're the first ones that to have a profession in their entire family. We have residents who have had other jobs. They have been in the pharmaceutical industry. They have taught biology and they wanted to become physicians. So you do not have to take the straight road to becoming a doctor. You can take whatever road feels best to you. You don't also have to have an MD. We have doctors of osteopathy, which is a whole nother training that people do. DOs as the end of there. That's not MD, it's DO. We also have residents that are DOs. We have residents who are foreign medical graduates. Like currently we have a resident who did her training in Brazil. So you can do your pathway to medicine any way you like. Back when I was a student, it was very much straight, like if you didn't get in when you got in, that was it. But now there are so many other ways that you can do anything like medicine, but if medicine's not an interest, nursing, there's also nurse practitioners who practice independently after nursing. There's physician's assistants. There's all sorts of healthcare fields that are wonderful, and it's such a great a job to be able to help people. And it's meaningful. It's a meaningful life. Like I don't, I just find a lot of a sense of accomplishment, just like earning a living, yes, but also like helping people. Like it's just, there's something about that that I just really enjoy. Um, okay, and then let's see. And I hope I emphasized that you do not have to be a biology major in college. You just have to take your pre-medical requisites. You don't have to, you can major in Spanish if you want. And then the specialty trainings, what else did I want to say to you guys? Oh, day-to-day activities. So it's very different for many OBGYNs, and that's the great part about OBGYN, I'll have to tell you, is the variety that what we do day to day. So we do not do the same thing every day. And if you're somebody that enjoys not doing the same thing every single day, it's a great field for you. Although there are OBGYNs who can do the same thing every day if they want. They can be in clinic Monday through Friday if they want. But for me, like Mondays are like my clinic day where I have, uh, uh, patients that I see, private patients. They know that they're going to see Dr. Paik. Sometimes on Tuesdays, I will be teaching students like during their breast and pelvic orientation. So I'll teach them how to do pelvic exams on a simulation model, or teach them how to do breast exams on a simulation breast model. And then like I'll take a call like that night, like a Tuesday night, and then Wednesday I'll have the day off because I've been on call the night before. And then maybe Thursday I will be doing the resident clinic, so I'll staff that. And then sometimes on Fridays I go to the Sacramento County Jail where I do OBGYN care for the inmates at the Sac County Jail. So I do a variety of things day to day. It's not the same thing every day. And I love that. I love variety. I don't want to do the same thing every day. But some of my colleagues like to do the same thing every day. And you can do that as an OBGYN too. Like it's not like if you don't like to do the same thing every day, that it's not the field for you. And then I interact with patients all the time when I'm on call, when I'm before surgery, after surgery, when I'm in clinic, I will see patients. So they're part and parcel of what I do. But because I work at UC Davis, and I have a lot of administrative responsibilities, I also do that. But I do that during the work week. Sometimes I work on weekends, like I did on Saturday when I was on call. Um, And then, oh, my education and career journey. So, let's see. I went to UCLA undergrad. I went to UCSF Medical School. And then I matched into UC Davis residency. And anybody who wants to ask questions about the match, please feel free. I matched into OBGYN at UC Davis, which I was very happy because I just had to drive from San Francisco to Sacramento. And then I've been there ever since. Seriously, like I did residency for 4 years at UC Davis, and then I started working there, and then I haven't stopped working there because I love it so much. Um, and then I'm going to probably retire from there. Um, and we just had on Friday night our fourth year chief residents graduate, and we had like a wonderful celebration for them, a big party. Everybody was there cheering them on. And it was just a great thing to be a part of. That's the other thing I love is like seeing the interns in their first year, and then 4 years later, they're like these competent OBGYNs. They're going out there and practicing. And I love that transition too. I get to be a part of that, and I feel I'm so lucky to be a part of that. Okay. And then like advice for you guys pursuing healthcare careers. Yeah, if that's something that you want to do, don't let anybody um tell you you can't do something, or you'll see other people, you'll meet, and I certainly did when I was a student. I met a lot of people who very much discouraged me. It's like, oh, you don't want to do that. Oh, that's such a long road. You'll never be able to have a family, or you'll, they just discourage you. And I call these people, they're just not happy doing what they're doing. And anybody who discourages you or is angry or bitter, I think that they're just not happy doing what they're doing. And that's all about them. That has nothing to do with you. You guys have to just stick with your plan. If that's what you want to do, you just persist in doing it. And persistence is the key, guys. You don't have to be the smartest person. You don't have to get straight A's. You don't have to do any of that stuff. You just have to do what you feel is best. And if this is the life that you want, you just persist in doing it. Oh, what did I major in for undergrad? I majored in psychology, actually. I was going to be a psychologist, and then I for whatever reason, I saw a counselor at UCLA, and they were like, "What do you think about being a doctor?" And I was like, what? I never thought about being a doctor. I'm not that smart. And they were like, oh, no, 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 no. You can, I think you can do this. So that's kind of how I got into it. And then when I got into medical school, I loved OBGYN. I mean, it was instant love at first sight kind of thing. And that's the thing about my field. Residents who go into OBGYN, they just knew. They did OBGYN, and they just knew. They're like, I love what I am doing. It's hard, but I love it. And when you love something, you can't turn away from it. I also love taking care of women. Women are so fun to take care of because they take care of themselves. They don't mind going to see the doctor, or at least most of them don't. Hopefully, some people have not been scared off, but a lot of women listen to their doctor and they want to have better health. Okay, how do you handle the really hard cases and not let it affect you? Oh, Sam, that's a great question. Okay, that's hard. So that is one thing that you do get used to in this line of work. Any doctor has to deal with hard cases. Sometimes you deliver a baby and it doesn't go as planned. And it's not necessarily your fault, although society and the family tells you it's your fault, because some things just are out of your control, even though you do your best. So How do you handle the really hard cases? Well, we do talk about it. You know, we talk about it in an open way. It's called Morbidity and Mortality Conference. You talk about the case, people comment on the case, and you feel like, okay, what could I have done better? You know, you take the feedback. Um, but what I do is you have to find joy in uh, kind of other things about your job. So don't let one bad thing derail you. Because if you really, really look hard, there are other aspects of the thing that you are doing that you do really enjoy. So you have to find the other things in your job. Also, there's life outside of medicine too. So I have a family and they bring me joy. So sometimes you have to go for a run. Sometimes you have to go see your girlfriends. Sometimes you have to go out and just hash it all out. Sometimes you talk to your colleagues, like a friend at work who's like, you just tell them, God, I had a really, really rough one. And they understand because they've had those moments too. We're all human beings. We all have hard times. And that's just what unifies us. There is nobody in this world that gets to escape problems, worries, concerns, loved ones not doing well. No one gets to escape that. And if you think that they are, having this wonderful, beautiful life, they're hiding it from you. Okay, Jillian, you have your hand up.
Okay, hi, doctor. So, um, I also had another question. So, how
Yeah.
are you able to successfully have a family while also having, I feel like, kind of a demanding job, I guess?
Yes, a great question. Now, okay, we have OBGYN. I'm mindful of the time, but I can definitely answer this question. So, first of all, guys, don't, that is something that in the past was true when women were very minority in the healthcare field, and they had to work really, really hard in the face of a lot of men in medicine where they could not take maternity leave, they could not have families because it was really looked down upon or frowned upon, like you're not a real doctor because you're getting married or you decide to have a family. No. Me, I and most of my colleagues have children. The residents have children, sometimes multiple children. There is leave. You have to extend your residency out a little bit due to the leaves that sometimes you take for childcare. But you can do that. There's nobody that tells you that you can't have children, and you can have children. I have colleagues who have 3, 4 children, and they are juggling very, happy yet chaotic lives. They're fine doing it though. They work part-time. Their husbands as partners help. Their kids are thriving, they're doing fine. So you can do it. It does take work. It takes organization, and you have to extend your training a little bit from the leaves that you take. But there are students and residents who have children and have families outside of the job. So that is something that is definitely changing because young women are going into healthcare. I mean, really, I mean, they outnumber men in a lot of areas. My field, especially pediatrics, there are a lot of specialties where women outnumber men. Okay, Sam, I guess that's it.
Well, thank
I
you
could
so
have talked to
much.
you guys for an hour. You're probably like, oh, Lord, she can talk all right.
No, this was wonderful. This is a great specialty to cover. I know a lot of folks are interested in that in particular. So thank you for sharing your morning with us and for sharing your specialty. Everyone, please thank Dr. Peg, and we appreciate you. We will see you next time.
All right. Thank you so much,
All
Sam.
right.
Bye, everybody.
Okay, we'll jump into our next speaker. So Dr. Rebecca Mendonça is the Director of Pharmacy. She's at Sutter Medical Center in Sacramento. And in addition to the Residency Program Director for the PGY1 Training Program, before her current role, she served as a clinical specialist, including the emergency room and cardiac ICU. So welcome, Dr. Mendonça.
Good morning, you guys. I'll go ahead and start sharing my screen. All right, so thank you so much for having me. My name is Dr. Rebecca Mendonça. You guys can call me Rebecca. Pharmacists always go by their first name, in case you didn't know that. But we do have full, doctor credentials. But I do serve as the Director of Inpatient Pharmacy at Sutter Medical Center, Sacramento, as well as the Residency Program Director. And I'm here today to talk to you about what it would be to become a pharmacist. All right, so I put a slide in here that's myth versus fact. Most of folks, including myself, years ago, looked at pharmacy as counting pills. We all see them kind of out in the community, but there is so much more to that, including, especially inpatient pharmacists save lives every day. All right, so how do you become a pharmacist? And I just want to make sure my slides are advancing. I hope you're seeing what I'm seeing. If not, just let me know. One of my screens is working and one isn't.
Yeah, we're seeing it. It works perfect.
Perfect, thank you. So high school science, high school math, high school science, that's really one of the areas that's important to be excited about. And then typically candidates go to college for a bachelor's degree. So that usually takes about 4 years. And then they apply to a pharmacy program, which is a post-grad Doctor of Pharmacy program, or PharmD for short. And that is either a 3-year or 4-year program, depending on the programs. The accelerated programs of 3 years, they go year round. So even over the summer, you're taking full course loads, where those that are 4 years, typically you get a break in the summer, which allows you to get on-the-job experience through either work or internships. So pros and cons there. And then once you graduate with your PharmD, you can either go directly working in pharmacy, or you can do a hospital residency program. So much like a medical resident or a physician resident, pharmacy also has residency programs, either 1 year in duration or 2 years in duration. And that's kind of the other hat that I wear, is managing and mentoring those young in career to be proficient in clinical pharmacy. All right, so I wanted to do a brief overview of the different areas of pharmacy. Although I serve in the inpatient or hospital pharmacy, I had to do internships in these other areas just to help me figure out which area I was drawn to and which one I got excited about. So community pharmacy practice is the first area, and that's about 30% of pharmacists work in this setting. They are key community health resource. So what do I mean about that? So if my mom and dad have a question about a new medication that they've started, they can take that medication into any CVS or Safeway pharmacy and say, may I please, talk to the pharmacist. I'm confused about this medication. Can you help me out? So because they're so reachable, they are a great resource for folks, both for medication safety and really just understanding how to use your meds. There are a couple different subcategories of community pharmacy practice. Independent pharmacy, for instance, you may have heard of like Pucci's Pharmacy or Parkside Pharmacy or Innovative Pharmacy. Those are independently owned pharmacies. And then you have chain pharmacies. That is kind of your Walgreens, your CVS. And then you also have clinic versus hospital based. So those are outpatient pharmacies that might specialize in patients discharging from the hospital. So still outpatient focused, but really help bridging that transition for the patient from inpatient to outpatient. We also are seeing a lot of growth in this area. So many of these pharmacists, instead of being behind the counter and preparing the meds, they're really out giving, vaccinations, teaching, and kind of doing a whole medication management, looking for drug-drug interactions, all of that stuff. So they know a lot about drugs. So let's cruise and see the next area. So inpatient clinical specialist. So this is my background, where when I finished residency, I got a job at a hospital and I became an inpatient clinical specialist. You participate in medical team rounding. So what that means is you have the physician, you might have a physician learner, like a physician resident, and then you have the pharmacist, the respiratory therapist, the dietitian, the nurse. We have this whole multidisciplinary group that talks about each patient in the unit, and they go over how they're eating, how they're moving, how, what meds they're on, any side effects, how's their pain, all of that to really optimize the care for the patient. And so the pharmacist is obviously managing the medications and giving recommendations and kind of making decisions that are patient-specific factors. But the different specialty areas within inpatient, some of them are listed there: cardiology, critical care, emergency medicine. So you can see they differ in both their specialty and their area. And then let's keep cruising here. Ambulatory clinical specialists. So the word ambulatory means kind of a clinic out in the community. Patient is walking around and coming to appointments in the clinic. And so this patients often get referred here because they have a disease state that is kind of long-term. So it could be diabetes, could be heart failure, it could be neurology like seizure disorder. So there's a bunch of different areas, or oncology, that's another one. So I wrote down here, example, collaborative practice agreement. So a pharmacist referral from a licensed provider to order medication, labs, and other clinical tasks. And so guys, this is a really growing industry within pharmacy where a physician diagnoses the patient, say with seizure disorder, and kind of hands the patient off. I need you to go talk to my pharmacist. They're going to get you started on a particular medication, and they're going to kind of manage you. And so the pharmacist decides what medication to start the patient, what dose, and then sets an appointment for them to come back. So after they teach them about the med, they really are in charge of monitoring it. Some of the anti-seizure meds take lab monitoring, so they have to get their blood drawn and they measure the level of drug in their blood. And some of them are more based on, are they preventing seizures, yes or no? And then what's the side effect management? So the pharmacist is the one altering the dose based on how the patient responds. So that's a really growing area of pharmacy. Then there's academic pharmacy. So these folks are teaching. So if you're interested in mentoring and educating the next generation of professionals, this is a great way to do it. And we have a few schools of pharmacy here locally. So we have California North State University, and that's in Elk Grove. We have Toro University and UC San Francisco, that's in the Bay Area. And then we have UOP, University of Pacific in Stockton. So that kind of rounds out the Northern California options there. And then we have pharmaceutical industry. So this could be research and development of new medications. And I put there med science liaison. And what that typically does is you are in charge of educating the physicians about new medications or new indication for medications. So your colleagues are really, top notch and really well educated, and you're helping them out kind of choose the best option, which is great. And then there's research. So if you like working in a lab and really kind of being in the development phase of it, it's very exciting to understand how this molecule affects this receptor and what's the potential outcome of that. We have some really neat medications right now, one of which is CAR T therapy. This is for leukemia. And what it does is we take blood out of the patient and we put what's called a vector, almost like a virus on it. And we establish that in your immune system, and then we put that back into the patient. So effectively, the patient's immune system is attacking the cancer cells, which is fantastic. So very innovative there. All right, so I also want to go, after you graduate from pharmacy school, there's an option to do a residency and or a fellowship training. So I kind of listed for residencies, you have your post-grad year 1 and your post-grad year 2. So the difference there is pretty much if you want to go into hospital pharmacy, we really recommend a post-grad year 1, or PGY1 is what we shorten it to. And then if you want to specialize within the hospital, if you want to do pediatric oncology or specialize in cardiology, you have an option to do a 2-year residency. And then fellowships are more for academia and research and administrative. All right, so what was my path? So with being hospital focused, I did graduate with my PharmD, and I did do a 1-year residency. And then I specialized in emergency medicine and then ICU. So emergency medicine was really great because it's very fast paced. You get a call from a medic saying they're bringing in a critical patient. You get all the meds ready. We had kind of this like tackle box of meds that I kind of open up, and I'm preparing them in syringes and I'm handing them off to nurses. And then I'm recommending to the physician, I think we should redose the epinephrine, or I think we should give a dose of amiodarone. So I'm really kind of right there with the team. Folks that like this area, kind of like high pressure situations, like to kind of see everything. It was very interesting for me to, see patients right in front of me. But I kind of joked because I became a pharmacist because I didn't really want to touch patients. I'm not really squeamish with blood or anything, but I really want to touch patients. So I found the happy medium there. And then pharmacy also offers a lot of leadership and mentorship. So with me being the residency program director, I get a class of fresh grads that I can then mold into clinical pharmacists. All right, so within the hospital, there's the clinical operations, which is kind of what I talked about with emergency medicine or ICU or pediatrics or oncology. And then there's operational, administrative, and leadership. So operational is really how do we get the medication, how do we make the medication, and how do we deliver it to bedside so that the nurse can administer it? And there is so much in that has to do with regulatory focus, cost savings, operations, efficiency. So for those of you that have more of a process-driven mind, that is where your strengths are going to lie. So there's really something for everyone. And then the practice changes depending on where you're working. So you could be in a large academic medical center, or you could be in a small or rural critical access hospital. And your role changes quite a bit. In that small hospital, you're wearing a bunch of different hats. You're doing the operational efficiencies and the clinical recommendations. But you may not get those really critical patients. Where at Sutter Medical Center Sacramento or UC Davis Medical Center, those large facilities, they get the sickest of the sickest patients. And so we really have to educate ourselves on how to manage those difficult patients. So I haven't gone over preparing IV medications, but that's a really neat part of pharmacy where you have to go into what's called a clean room. It's a controlled environment. You put on, your bonnet and your gown and your face mask and your eye shield, and you're kind of covered head to toe in what we call a bunny suit. And you put your hands into this hood and you're, drying up and preparing medication. So everything that's given IV, intravenous, into the hospital, we prepare it in that setting and in that way to make it very safe. The other thing that pharmacists are known for is ensuring medication safety. So again, for you thought process driven folks, thinking big picture of, okay, if we have these two medications that sound very, very similar to each other, how do we prevent the medication error of the physician potentially having an accent and ordering one med, and we accidentally think that they say a different medication name? So you can see from there the sound-alike medications, the look-alike medications, all of those sort of things. We create processes to try to prevent medication errors. And then supporting our nurses and physicians, which are really our team members there. And speaking of that, this is a picture that's supposed to depict, multidisciplinary round. So that's where we go bedside to bedside and talk about each patient. And that's where we, really focus our medication safety. Just jumping ahead there. And then in the ER and the ICU and other areas, but primarily those two areas, Code Blue response is another really important thing that the pharmacist participates in. So Code Blue is, what we mean by that is the patient's in cardiac arrest. The patient's heart either stopped or it's gone into a rhythm that's not compatible with life. So often we have to give a number of medications or do physical shock or CPR to the patients in order to save their life. So here in the hospital, we respond to all emergencies, which could include Code Blues. It could include strokes, seizures, all of that sort of thing. And so there we provide medication management as well as help out with rapid decision making. And you can see that's exactly what a code tray looks like, where that first drawer is all the medications lined out. And you have the paddles for shocking on top, and then you have, fluids and supplies and that sort of thing in the lower drawers. All right. Did I always know that I wanted to be in pharmacy? I don't think I was really introduced to pharmacy until college, but I knew I wanted to do something sciencey. So I was pre-med, I guess, is where my mind was going, is I wanted to be a physician. And I didn't really know what aspect I wanted to practice, but when I learned about what pharmacy does, that's really what I knew fit me. And the reason that I say that is, like I said, I didn't really want to touch patients. Talking to patients is fine, but I didn't want that to be my primary role. I really wanted to understand kind of the science behind it and provide recommendations that are valuable without having to kind of be front and center with the patient. I also wanted a career that provided me a good work-life balance. When I thought of, not all physicians are like this, but back in, a decade ago, they had to carry around a pager and, they were always on call, and, it has evolved over the years. But I will say pharmacy is one of those professions where you clock in and out. So once my clinical specialists clock out for the day, they have someone else that manages their patients overnight, and they get to go home and be present with their family or have hobbies or whatever they want to do in their free time. Was my path typical or not typical? So I would say the first half of my career was very typical. I worked hard in pharmacy school. I did a residency. I got hired on at a hospital, and I worked as a clinical specialist. And that was kind of my goal. And I achieved that very early on in my career. And then I thought about, well, what's next? I will say, being a hospital pharmacist, the hospital is open 24/7, 365, right? So although I worked primarily during the day, when our night shift pharmacist went on vacation, I had to work graveyard shift. I had to cover our evening shifts went all the way to midnight. So I would have to do those a couple times a week. And so when I thought about what's next with starting a family and settling down, I wanted to kind of evolve my career to be able to support daytime shift hours. And that's one of the reasons I went into leadership. I also, was kind of nudged by a lot of my mentors to go into leadership, so there was that as well. But there are some flexibility in hours with hospital pharmacy. Things I like about pharmacy versus don't like. I really do feel part of the patient management team. Physicians often ask for pharmacist advice prior to deciding what to do. We also, like I said, provide that medication safety. So I sit on committees that, help kind of dictate what the physician is going to order before they even ask the question. So basically, when a patient is diagnosed with sepsis, they log into the computer where we do our orders, and they type in sepsis, and they have a whole list of, it's called an order set of, I want to order this, 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 this. The creation of that document is created by mostly pharmacists that say this antibiotic is the best to give. If they have a penicillin allergy, then you give this as an alternative. So we really are guiding care in that way. And then work-life balance, I touched on that. So I wanted to give a couple of patient examples, just patients that I've come across in my career. There was a patient in residency that I had that was a pediatric patient. He was probably about 2.5 years old, and he choked on a hot dog. It's funny, as early parents, we learn to kind of cut the grapes in half or cut the hot dogs long ways, because the size of that, if it were to be aspirated or down the airway, then a patient can choke. Well, this young boy, he choked on a hot dog, and we had to perform not only like the Heimlich maneuver, but we had to perform full CPR. He went into cardiac arrest, and he came back, and his heart started again. He started breathing, but the amount of time that we were doing CPR, unfortunately, there was the period of time where the oxygen wasn't reaching his brain, and afterwards he developed seizures. And so I was part of the team that really helped try a seizure medication, and then he had a side effect, try a different seizure medication, and he had breakthrough seizures, and then really optimizing the care and discharging the patient on the appropriate seizure med. So just the fact that he was so young, and it was such a story of survival, and then obviously working with the mom and dad to educate them on giving the medication when he discharged. There was another patient that a woman probably in her 30s that went on vacation, and they rented a jet ski. And the story is there were some kind of unruly teenagers that were being reckless on the jet ski, and they actually hit her on her jet ski, and her stomach was pretty much sliced open. We were able to salvage the organs in there and sew her up, but the antibiotics is what I was really managing. But every other day in the ICU, she had to go back to the operating room to kind of the surgeon opened her back up, cleaned out the area, kind of sewed back up as much as they could. And she was so swollen, and her belly was so distended. And so you worry about antibiotic penetration, making sure she's not going to get a worse infection. And because of the number of times that they had to open and close her and the antibiotic changes, that's another patient that really kind of stands out in my mind as making a big impact. So you can see here that every high stakes patient helps you grow as a professional, because things that I learned along the way managing those patients have stuck with me this long. And then it's also very much a team-based problem solving. There may not be a perfect answer, but we talk about the pros and cons of each option, and we decide on the best option and move forward. All right, so how do you get started if you are interested in becoming a pharmacist? So I wrote, get excited about math and science class, and then perhaps some of the following. But really that first part, If you have a talent for those, or if you just enjoy those are very helpful, because a lot of the prerequisite classes that you're going to be taking in college and grad school are going to focus heavily on those. And then the other 3 bullet points are optional. I did not necessarily do all of these or really any one of them, but I wrote volunteer in a hospital. So once you turn 18 years of age, you can submit your application to be a volunteer at Sutter Health. And the volunteers at Sutter Health can do a few different things. They come in our department and they get to deliver medications, or help put stickers on medications to prevent that look-alike drug error. But they also get exposure. They get to ask pharmacists, why do you do this? What do you enjoy? They get to see what they do at bedside. So it's a neat option. There's also volunteers in the emergency department. They get to, see all sorts of stuff. Or in the neonatal ICU, they get to hold the babies and feed them, which is really exciting. You can also become a pharmacy technician. So technicians assist the pharmacist with a lot of the drug preparation and clerical duties. And again, exposure is very important. And then you can also shadow an inpatient pharmacist. So if you have a friend or family member, or someone that is willing to let you shadow, that can be really helpful, just to help expose you to make sure that it is something you're interested in. But pharmacy in general is a fast-paced environment. It's also very team-based care, so working well on a team. We do have direct patient impact. We have job security, professional growth, and then we have a healthy salary. I put between $125,000 to $250,000. That is a very big range. And depending on what area of pharmacy you go into, you kind of land within that range. But I would be happy to take any questions that you might have.
Do we have any questions? Y'all are quiet this morning. That was a great overview. I really appreciate all that overview of the different careers, and adding things like the salary and the job education requirements and all that is really, really helpful for them as they're working through their career decision. Why did you pick this career in particular?
I was pre-med. I wanted to be a physician, and I was kind of debating people physician or animal physician. So I was kind of in the veterinary kind of thought process. And I think that really spoke to, I just didn't want to be dealing with patients face to face every single day. I really liked the science aspect. I really liked treating them and helping. But there was something there that was, maybe not for me. And my dad kind of guided me this direction and exposed me to pharmacy. So just know that in healthcare, there are so many different avenues. So if something, is drawing you one way, there's probably multiple different areas that you can consider. Well, thank you so much. Oh yeah, go ahead.
I had one other question that got sent to me privately. What do you do with patients that don't trust you or don't trust in the medication?
It's so unfortunate when healthcare professionals or healthcare process in general loses the trust of a patient. That can happen if they get prescribed the wrong medication or have a side effect or something goes wrong. And so really building trust is aligning what you say and what you do. And that can really be done over time. So working closely with patients just to make sure that they understand exactly what they should be doing, having that open line of communication of a phone call or a direct message in case there's an issue, but really developing that trust over time by aligning what you say and what you do.
All right. Well, thank you so much for your time. Thank you for spending your morning with us and for sharing about this career. And if there are any other questions, I will send you a follow-up email. But thank you and have a wonderful rest of your day.
Thank you, Sam. Thank you all.
Okay, we'll go on to our last speaker of the day. So Barbara Goen is a registered dietitian, certified and a certified diabetes care and education specialist. She currently runs an insurance-based private practice in Sacramento, providing nutrition counseling services, as well as part-time professor at Casumas River College, teaching intro to nutrition and cultural foods across the world courses. So welcome, Barbara.
Hello, everyone. Hi, thanks so much for having me. I'm really, really excited to talk to students, especially. I feel like I wish I would have had something like this when I was your age, because I felt very, like just not super knowledgeable about, I feel like the medical field. And so I was actually one who was a little bit scared of the medical field and actually told myself I didn't want to go into the medical field, which is really funny where I'm at now. But I was not into like patient care or just medical, like being in a hospital setting really kind of scared me. And I think it's because I didn't have that experience or have people kind of showing me how to do that or telling me it's okay or sharing these kinds of stories. So I think that's really, really powerful and a really good message. And I wish I would have had that as well. I'm going to share my slides here so that I can I just came up with a couple of things to kind of share, not only just like my story, I guess, but to share specifically about like what registered dietitians are. I feel like there's a lot of miscommunication or like misunderstanding about registered dietitians. And we hear this like word nutritionist a lot, and there's a lot of also like in the realm of like wellness influencers and social media, there's a lot of like these experts out there that are saying all this nutrition information online. And so it's really important, especially going into the medical field, like to understand the like actual credibility of the nutrition sciences, and trying to uphold that credibility again in this world of so much information. Do you guys see my slides? I just want to make sure because I have it like a dual screen going on. So I just want to make sure that everyone can like see the slides that I have shared.
Yes, looks good.
Okay, perfect. Okay, so the first thing is again just making the emphasis about the credibility and credentialing process of becoming a registered dietitian. There's a lot of people that can say like, "Oh, I'm a nutritionist," right? And a nutritionist can mean you're a registered dietitian, but it doesn't always mean that because anyone can call themselves a nutritionist by taking like a weekend course, nutrition 101 course, and then saying I'm a nutritionist. But a registered dietitian, you have to actually go through all the steps. And maybe some of you have already looked into this before or have thought about this, but so now becoming a dietitian, you have to have a master's degree through an accredited program. And I will tell you kind of what I did, because again, I kind of went a different path because I didn't want to be in the medical field, but I ended up going there anyways. So after or during your master's degree, or depending what program you're doing, whether it's bachelor's, dietetics, and then the master's, you will also have to do an internship, and it's 1,200 hour plus internship. Typically, it could be spread out, or it could be, for just one full year altogether. And you do these supervised experience hours, usually through different rotations that are really, really fun. You'll do clinical rotation, but then you'll go from clinical to food service to community, and then to like an outpatient counseling setting, which is what I do right now. And being a dietitian is really interesting because it's not always just one small set of skills that you have to employ, like one specific, specialization. I feel like especially becoming a registered dietitian and going through the schooling, like the wide range that you kind of have to know to sit for the registered dietitian exam is pretty crazy. I remember still taking my exam. It's been about 6 years or so. So I remember sitting for my exam, and you go from having all this clinical knowledge about chronic illnesses to then also having to know like what type of tile needs to be in food service hospitals in order to have cleanliness, right? Just pass food safety inspections. So you just have such a wide range, which is really fascinating. And in order to keep up with all that, every 5 years, you have to have your continuing education and you have to submit this whole portfolio with all of your hours and what you learned from those hours. And then they have to basically you have to like submit that, and then they have to tell you whether those hours count for the 5 year period that you kind of went through. So I just recently had to submit mine last year, and it was a really kind of long process, but really, really cool. As well, because I feel like continuing education is so important, especially in the field of nutrition, because things are changing all the time. So, my pathway and how I kind of went about it is actually my bachelor's degree from Sacramento State was in intercultural communications. I went into a communications degree completely. I was going to go into a whole different other pathway. Um, and so my background, which I honestly now being in the medical field, I actually think was a huge advantage for me because there's so much patient facing, and that's where I feel like I thrive, is a lot of more patient facing, talking, discussing, relating, communicating with literally patients and having to provide, from what we understand in the clinical side of things, but having to relay that message towards the patient themselves and understand them, understand what they're going through, talk to them about what they're going through and what things can help, right, and support them. And so I feel like communications at first I thought was like, oh, I just did all that and it really didn't even pay off. I actually think was one of the best things that I did. And so when you're in your career, whether you're going into pre-med or med or any of these kinds of things, I think it's really important to not like like it's not just math and science. Like I feel like there's so much more skills that you can also employ and try to hone in on, especially around communications. So because I did my bachelor's degree, I didn't have a lot of science courses, which I love math and science. I really did love it. It's not that I didn't like those classes in high school and things like that, but um, for my prerequisite in order to get into my master's program, I had to, within a span of like a year and maybe like a half, I had to take, microbiology, organic chem, biochemistry, anatomy and physiology. I had to have this whole like pre-med, basically kind of prerequisite course year that I did while I was working. And I did it through my local community colleges and was able to complete that and get my science courses up. So that was what I had to do from there. And then I got accepted into the Eastern Michigan University online master's coordinated program. And when I say coordinated, what it was is it's a 2 year program. But because I didn't have like my internship during that time, for the coordinated programs, you're doing your internship alongside your master's program. And so you would do maybe 4 or 5 classes a semester, but then you would have like 1 or 2 rotations, maybe 1 to 3 times a week. You would be in a facility or your rotation with a preceptor doing the actual work that you're studying about in your master's program. And so that was just such an immersive program. I may be biased, but I highly do recommend like a coordinated program if you can. Not everyone does that, but it is, I feel like, one of the best routes just because you're really able to apply what you're learning real time instead of learning it all and then doing it later. I feel like you're kind of getting the best of both worlds. And so the coordinated program was really cool. And I was able to receive my master's in dietetics. And so because of the accredited program, after you receive the actual master's, then I was able to sit for the exam within a couple of months and passed the registered dietitian exam. It took about 1 to 2 months or so to study for it. It's a very kind of extensive, like every other, credentialed kind of thing. It's a very extensive exam. And it was, I wanted to take my time after finishing in order to get it done. And so within that time frame, so right in, you saw that it was 2019, so it was right before COVID hit, that I was actually able to get a little bit of my bearings of like finishing my schooling, doing all that, and then be able to kind of hit the ground running. And I started doing kind of like consultant work-ish. for a little bit, but my first really full-time job, I had a 3-month-old baby, and COVID was literally there. My baby was born in March of 2020, so literally in the throes of COVID, I had my first full-time job working at WIC. So WIC is a community, it's really community nutrition, but it's women, infant, children. It's services that are provided based upon your socioeconomic status and your eligibility for that. Women who are pregnant, feeding, breastfeeding, and children under 5 years of age. So we were able to provide basically food and food coupons, or now it's not a coupon anymore, but it's a credit card, and we were able to provide them with food. And this program is once you become a dietitian or you're learning about it, you learn about a lot of community nutrition programs. And WIC is one of the most successful programs that I think any kind of large scale based, federally funded kind of program is, because they actually save money. Even though we're paying into this program, they found that for every dollar spent on this program, they actually get money back, because we are really providing good care of providing healthy foods for women, for kids, and especially in the early stages of a child's life, which is really important when you start to learn about kind of developmental nutrition like throughout our years. And so that was like such a really, really cool experience to be able to work during COVID with the people that needed that food the most. And that being my first job, it taught me a lot about counseling. It taught me a lot about working together with my colleagues and coworkers during a very stressful and scary time. And one of the things that was really interesting that I kind of feel like is a really big theme that I want to pass on, especially from my experience, is that I was able to get that first job because of a preceptor that I worked with during my internship hours that I did. And I was able to use kind of that connection to then get a job more locally close by, working at the WIC agency that I did work for. But it was based upon from my previous preceptor who kind of knew the person running that specific agency, a community resource project. And so that was how I was able to get my first job, is just based solely upon the fact that I knew somebody and I had that connection, and I was able to build a good relationship, and they were able to put in a really good word for me. After I kind of did a year or so of the WIC job, I then actually got my second job at Sutter. And I was working there as an outpatient dietitian, doing a lot of nutrition counseling, and it's also how I became a certified diabetes care education specialist. So the CDCS, which was a huge goal for me. I really wanted to work in diabetes care as a dietitian. That was one of my most like number one 5-year kind of goal markers for me going to become a dietitian. And I was able to do that because in Sutter, specifically in the outpatient setting, not in the clinical setting, but outpatient setting, we do a lot of diabetes education there. And I was also able to do some like high risk diabetes med management with a doctor who was a diabetes specialist doctor. We worked together in order to provide that care. So that was really cool. And I was able to get all that experience. And I got the second job based upon, because I also was able to, I interned at Sutter during my master's program. And because I interned at that time, my preceptor reached out to me saying that they were hiring and that they were looking for dietitians, and I was able to apply. So I got my second job, which gave me so much experience based again upon a connection and a relationship that I had made during my time as a student. And so again, very valuable. That again, it just keeps coming back to this thought that even wherever you are, if you're volunteering somewhere, if you're a student now and you're going somewhere and you're making these networks and relationships, I feel like that really has made everything for me to be able to become a dietitian and get the jobs that I've been able to get. Because my third and final, hopefully, job is I'm actually, private practice owner for an insurance-based private practice. And that job was also came to my to my view because of a dietitian who was retiring. That was another preceptor of mine that I had to do when I was a student, and she had a private practice here in the area. And I reached out to her asking any advice she had about a dietitian trying to have my own private practice. And she said, "I'm actually selling my private practice. Are you interested?" And so that was really, a very pivotal kind of moment where everything kind of came together in the universe for me. And I was able to get this practice and was able to, and that's what I've been doing the past 3 to 4 years now, or going on my 4th year. It's been the most rewarding, and I can't believe that I'm already here doing that. But again, all three of these steps have been because I was able to build that relationship and connection and stay close and in touch with these people that made a difference while I was a student. And that's how I was able to get all of these positions. So as a private practice dietitian, it's a very flexible job. Like today, I'm at my home office, instead of like in an office necessarily, even though I do have it in office, an office that I see patients at as well. The thing that is really hard though is it is very challenging still to have a private practice because you're just dealing with a lot of things all at once, and you're having to wear a lot of different hats. So, I'm dealing with insurance companies, I'm dealing with the billing side of things, I'm dealing with claims, I'm dealing with so much outside like administrative stuff. And having to kind of know all of those things. So again, private practice, yes, you can obviously hire people to do these things, but knowing those things and how to do them first, I think is very essential before you actually go and hire a person to do it for you. And then, I have an administrative assistant that helps me with things, just kind of thinking about business side of things. So even if you're going into the medical field, that doesn't mean you're just wearing a medical hat the whole time, right? You're also having to wear a bunch of different other skills and practices and things that you're having to put together for that. And then, of course, my main thing that I try to do the majority of the time that I love to do, which is patient care. And patient care, really, again, I do a lot of like one-on-one nutrition counseling. So it's a lot of communication, discussion, and education with a patient one-to-one, very individualized based care for them based upon their chronic diseases, their blood work, going through all of that with them, providing a nutrition assessment in terms of what their needs and goals are and what I'm going to be focusing in on, and really trying to even see things like, what are their nutritional barriers and problems that we're going to be facing and discussing and working through that. I love to think of nutrition counseling as a very collaborative type of care. It's not me lecturing a person or just giving them a handout to tell them that this is what they need to be doing, but it really does come down to like understanding that person and then being able to use my clinical care medical knowledge in order to create applicable, practical solutions for that person. I also do create like handouts and become creative with when I counsel or educate someone, what kind of piece of paper can I visually give them to look at in order to understand and dissect this information a little bit better. And that makes it really fun if you get creative or have any creative things like that you like to do. And I also, take on students. I have like an intern right now that is observing me. And I love to take on students to observe, my patient care, my counseling appointments, and kind of help, with that process because it's very, very, very rewarding. So, um, and one of the things that I feel like people, when they think about what dietitians do, is that we get kind of grouped together with people like just like a weight loss coach or like a diet coach or something. But dietitians are just way more, much more, and do way more than kind of like weight lossy things. I like to kind of honestly look at so much more impact and healthy promoting behaviors and habits of patients through food rather than think about this like weight-centered approach towards their health. And so I like to look at, their limitations, their barriers, what kind of support that they need, what kind of resources are in the area, because I do deal with a lot of people who are on Medi-Cal. What kind of resources do we have and programs do we have in the area for them to have better access to healthy foods, right? We also, while counseling around weight loss or talking about weight concerns is just a part of the day, I really try to look outside of the scope of just that aspect and understand all of these other foundational skills and practices that we need to look at for their overall health and to have better health outcomes. And so, I'm dealing with patients who have chronic, like chronic kidney diseases and cardiovascular issues, diabetes, I have a lot of eating disorder patients as well. And I mean, just like the whole run of it, right? Hypertension, so elevated blood pressure. I mean, the list of conditions that we look at are very wide. And sometimes it's very there's like a lot of puzzle pieces that you're constantly fitting together or looking at, maybe separately, and then trying to piece it together in order to provide good medical information and recommendations for them. And so that's always a really rewarding, again, part of the job, especially if you're know yourself to be that kind of person where, I'm looking at the sustainability of the diet that they're on and how they're able to do it, the long-term success of those healthy behaviors and outcomes, trying to help a person kind of promote listening to their body and their hunger and fullness cues and what that means, maybe clinically or medically as well. Individual habits, body image issues around, how people feel around their body and their relationship to food and their relationship to themselves as well. So it's really fascinating, especially in the outpatient setting as a dietitian, that I wear a big kind of counseling hat, right? So I always am not just approaching food in this like, eat more fruits and vegetables, period. It's like, well, how do we actually allow for a person to feel like they have access to those things, like they're able to cook those things? Where do they put those? Like, where in what part of their day do they put those things, right? Like, how does all that fit into it? So it's a lot of on the spot kind of having to think, and not so much like an algorithm of like this person does this and then you do that. So it's a lot, you have to be a lot of creativity in order to do kind of nutrition counseling as well to make it applicable and approachable. It can be very, very challenging, right? Because you're on the spot. It's not always just this formulaic type of performance, right? It's like um, you have to be kind of on your toes a little bit and thinking and grabbing all the tools out of your toolbox in order to help support that patient. And so I wanted just to kind of, the key takeaways from some of my experience, but also going forward for you guys is kind of thinking about the relationships and making good connections really matter, even if you're a student, especially when you're a student, making a good making a good impression on your preceptors, your mentors, your teachers can make a really long lasting impact even outside of being a student, could lead you to the success of having lots of jobs down the road like I did for it. I felt like as soon as I knew that I wanted to become a registered dietitian after my bachelor's degree, I felt like I had the biggest game plan. Everything was ready to go. And I was like the best student ever at that point because I had this like end goal, So that was really, really important. But the reason why I was able to do that is because I knew myself, and knowing myself, I feel like was really important to understanding like, is this the route that I want to take as a registered dietitian? Because it's not always easy, and it's not always something that everybody can do, right? And not everyone can have that kind of approach. And some people, they want to be kind of away from the patient care aspect, but still be in the medical field. But there's some people who kind of want to be in the middle of it, in the middle of the chaos. And so knowing yourself and what kind of level you want to be at there, and staying open and very curious, especially in the nutrition space, is very important. But above all, providing like evidence-based scientific actual care, kind of fiddling through or getting rid of debunking all of the misinformation. So you kind of have to stay really open and aware of what's going on out there in order to be able to apply that to your patients, and to your clients or whoever. And so I feel like that's always the biggest thing that I tried to lead with when I speak with or when I think about my practice. Okay. Any questions I wanted to answer, see if anyone had any. Yes, Jillian.
Hi, okay, I had two questions. The first
Yeah.
one was like, how did you decide that you wanted to be a dietitian? Like, what gave you that like motivation? And the second thing was
Yeah.
like, how do you like differentiate like actual nutritional advice that's like factual versus stuff that's I guess like made up online by influencers?
Oh my gosh, yeah, two perfect questions. So I would say the first question, the reason why I want to know is one, I was kind of interested in the space of nutrition, just by myself. I was just kind of interested in it overall. Started kind of meal prepping and doing things that really got me excited in the nutrition space. And I was looking up kind of like what jobs you can kind of have in nutrition that were credible and made money and were actually like noteworthy, I guess. And one of the things that kept coming up was registered dietitian. Registered dietitian, they have a lot of this in like public health spaces, like for if you wanted to work for the state. So I kept seeing this word, registered dietitian, was the only one that was coming up as like a job, that you can like apply for. And I was like, what is registered dietitian? And so then I looked up all the ways in which to become one. And then that's how I was able to set up my game plan to become one after I had realized, oh, okay, well, this is like a really good job and it's in the nutrition space. And I think this is something I want to do. And it wasn't until I started the master's program that I was like, oh my gosh, I'm exactly where I need to be. So I kind of took a chance on myself for that. Now, in terms of like deciphering the differences, my biggest red flag that I often will say is, and this is for like all things, but specifically for nutrition, is when you have a wellness influencer or someone on social media say things that are very black and white. When they say this causes cancer, this is definitively what is happening, or this food causes this, and they don't have like a gray area or like a, well, it depends kind of situation. When it's very black and white, it typically is a red flag and not very factual. Okay, because most science, and I'm sure, with you all, if you've taken any science courses, when we talk about research, there's a lot of like nuance. There's a lot of in between, right? It depends. With this person, it might be like this, but with this person, it might be different. And so when we see these headlines that are very like catchy, right? Because they say, if you eat bread, you will blah, 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 finish that off, right? That's when okay, this is typically a red flag and not factual. Does that answer your question?
Yes, thank you.
Okay, perfect. Anyone else? Okay, great question. So how do we work alongside other clinicians? So in the space, in a couple different areas, when I was in my master's program and I was doing internships, right, we did a lot of rounds. So when you're in a clinical space, you work alongside the speech therapist, right? Because with speech therapy, a lot of times they're the ones that are going to clear a patient to actually eat food by mouth, right? They're the ones, if you ever see patients like on tube feedings or anything like that, right? So you're working with all of the providers in order to make sure that a patient is eating and eating by mouth as much as possible, right? In my spaces with my diabetes care, I worked alongside doctors who specialized in diabetes in order to make insulin changes or medication changes or kind of restructuring their eating regimen based upon their medication, all of that together. And so working alongside a doctor was very, very valuable. And one of the things that I love the most, I think, because you have to work alongside them in order to create better care for your patient. So I feel like medical field, a multidisciplinary approach where you're working with all these different other groups and communicating with them effectively is actually one of the best things that you could do for better patient care outcomes.
All right. Well, thank you for this wonderful overview.
Of course.
This was a new addition we've had, and I appreciate you talking about the difference between, nutritionists and social media and all of that, because I think
Yeah,
that's really helpful, especially nowadays, in looking at, where the science is. So I
totally. Yes.
appreciate your time. Thank you
Of
so much.
course. Very
Enjoy
nice
your
to see you all.
afternoon. Everyone,
Thank you
please
so
thank
much.
Barbara. All
Thank you, you
right.
guys. Take care. Thank
And
you.
our winner for the gift card today is Julia Jukov. And so I will send you a $5 gift card, and we will see you tomorrow at 10 a.m. Thank you.